How a free society deals with pandemics. Let's have a look. Hello everyone, Florian.heise here, and welcome to another episode of HeiseSays. Grab your morning stein of coffee, top it up, and let's have a look at this article from the American Institute for Economic Research. Now, one viewer was very keen for me to have a look at this, and, well, I'm quite interested as well, because we only seem to be receiving one narrative in the media, one opinion on how to deal with this global pandemic that we have. So the fact that the American Institute for Economic Research have got this article, How a Free Society Deals with Pandemics According to Legendary Epidemiologist and Smallpox Eradicator Donald Henderson. So I think this is certainly something we should all be looking at and discussing. It's something you'd hope would be debated in Parliament. It's something that you'd hope the news would be discussing to give alternative opinions. Although, I think, frankly, it would be considered a heterodox opinion. Wrong think by some people, and maybe not even given the light of day. How could we dare consider it? We must sacrifice our liberties one after the other for the greater good. For the greater good. How many people have you seen praising Dan Andrews? I think people just want an authoritarian leader just to rule over them like a king. Sideshow Bob was right, wasn't he, in South Park? Oh, South Park. Simpsons. What am I doing? Showing my age here. So let's have a look at this. Economists have written for hundreds of years on the role of government in solving economic and social problems. Really? What about causing them? A theme has emerged throughout. Policy officials are quite often ill-informed or have bad incentives compared with what individuals, markets, institutions, and societies can achieve on their own. Economists have documented how government intervention leads to various unintended economic consequences and even human rights abuses. Well, you've got to understand, the most dangerous thing to people's survival, the thing that's killed more people through most of history, has been their own governments. We prefer private governance to public governance. We have applied this logic against socialism, fascism, war, macroeconomic planning, public goods, monetary policy, counter-cyclical fiscal policy, environmental regulations, and 100 other issues. We've made a solid case for pure freedom. You can see why I'd be interested in looking at their perspective on this. Cases for freedom don't seem to be that popular in Australia. I'm trying to organise some interviews to just discuss and learn how the libertarian movement is going here in Australia. Is it just a fringe movement? Is it growing? Are more people going to realise how much control the state has over them because of what's happening? I think we're going to see an exodus of people leaving Victoria. I think this will be the fine. You know what? This might actually have an impact on property in Queensland. Everyone's selling up in Melbourne, getting out and moving. It might even tank their property even more. If you've had enough, if you've been locked down for 6 weeks, if you've lost your freedom, and you're saying, that's it, we're getting out, I don't care, sell, go. What do you reckon? Always comes back to property, guys. Always. And yet here we are, living in times when the state is controlling our movements, shuttering businesses, defining who and what is essential, dangerously disrupting supply chains, forcefully closing schools and churches and restricting travel. A shelter-in-place order is something of a liberal nightmare. The worst possible use of coercive power against individual rights, and the results have been catastrophic. It's my view that we've been ill-prepared to deal with this onslaught. We have a very thin record of writings that make the case that freedom, market forces, and private governance are better than government quarantines and closures in dealing with pandemics. So where do we turn for better arguments and a better case? Now, I'm going to have a shot of coffee while we wait for that. I mean, that's a very good point. That's a very good point. It is my view that I've already read that. Part of the problem is that as economists, historians, and political philosophers, people are telling us to stay in our lane and not comment on medical matters. In general, this is good advice. But there is a problem. The computer scientists and theoretical physicists who dreamed up this lockdown haven't really had serious medical training either. And they sure haven't stayed in their lane. They certainly have cared very little for the economic implications of their plans. Well, most people have absolutely no exposure to economics. Is there even any economics education in any medical degrees? Where do we turn to for competent commentary on the medical aspects of quarantine and lockdowns? Where is our credentialed and experienced expert who can provide weighty evidence that this is the wrong course? Let me introduce you to Donald A. Henderson from 2008 to 2016. He was the 20th century's most acclaimed disease eradicator. In particular, he is credited with ridding the world of smallpox. Respect. He was born in Lakewood, Ohio, son of a nurse and an engineer. Just think about this. Think about this. If your mother is a nurse, they're like tough as nails. I've heard of stories of kids having broken arms and being sent to school because they've got no time for kids screwing around or going, oh, I'm sick. Oh, all the motherly care has gone out the window. It's been used up with their patients. He went to Auburn College for undergraduate and graduated in medicine from the University of Rochester. He trained 2 more years at the Epidemic Intelligence Service of the Communicable Disease Center and moved to Geneva to head the World Health Organization's division focused on smallpox. I encourage you to read his entire biography posted by Johns Hopkins, where he headed a brilliant epidemiological team. In 2006, at the order of the Bush administration, some computer science programmers with a small group of public health officials began to restructure a pre-modern idea of quarantines, closures, and measured lockdowns. This way of thinking is not just pre-modern. It turned the logic of modern medicine on its head. It was based on a theory that we should just run away from viruses. Whereas Dr. Henderson's whole life had been devoted to implementing the great discovery of modern virus theory, that we need not flee, but rather build immunity through science, either natural immunities or via vaccines. At the age of 78, Dr. Henderson swung into action and composed a masterful response to the new fashion for quarantines and lockdown. The result was disease mitigation measures in the control of pandemic influenza. Henderson, though, listed last, was the primary author, along with co-authors Thomas V. Inglesby and epidemiologist Jennifer B. Nuzzo, and physicist Tara O'Toole. Here is the riveting conclusion. Experience has shown that communities faced with epidemics or other adverse events respond best with the least anxiety when the normal social functioning of the community is least disrupted. Strong political and public health leadership to provide reassurance and to ensure that needed medical care services are provided are critical elements. If either is seen to be less than optimal, a manageable epidemic could move towards catastrophe. Sounds familiar, doesn't it? Below we provide a full version of the article. It should help us to better manage epidemics in the future. And we'll go through this. I'll need a shot of coffee, 1 sec. Because I think this is, very relevant. Disease mitigation measures in the control of pandemic influenza. Abstract. The threat of an influenza pandemic has alarmed countries around the globe and given rise to an intense interest in disease mitigation measures. This article reviews what is known about the effectiveness and practical feasibility of a range of actions that might be taken in attempts to lessen the number of cases and deaths resulting from an influenza pandemic. The article also discusses potential adverse second and third order effects of mitigation actions that decision makers must take into account, Firstly, the article summarizes the author's judgment of the effectiveness and the adverse consequences of the range of disease mitigation measures and suggests priorities and practical actions to be taken. The threat of an influenza pandemic, especially one caused by some variant of the highly pathogenic H5N1 avian strain, has alarmed countries around the world. There is universal agreement that the key to influenza prevention is vaccination, and both funds and research are now being expended in pursuit of an effective vaccine. However, producing a satisfactory vaccine will take at least 6 months after a new strain emerges, and this is demonstratively capable of causing a pandemic. Antiviral drugs offer hope of preventing some cases and possibly diminishing the severity of the disease if they are given within 24 to 48 hours after the onset of symptoms. But supplies of these drugs are limited. The rapid development of virus resistance to the drugs is feared, and they are costly. Accordingly, there's been interest in a range of disease mitigation measures. Possible measures that have been proposed include isolation of sick people in a hospital or at home, use of antiviral medication, hand washing and respiratory etiquette, large-scale or home quarantine of people believed to have been exposed, travel restrictions, prohibition of social gatherings, school closures, maintaining personal distance, the use of masks. Thus, we must ask whether any or all of these proposed measures are epidemiologically sound, logistically feasible, and politically viable. It is also critically important to consider possibly secondary social and economic impacts of various mitigation measures. And I'll just scroll up here to see when this was written. I mean, this is quite current, from May this year. But this was written in 2006. Over the years, various combinations of these measures have been used under epidemic and pandemic circumstances in attempts to control the spread of influenza. However, there are a few studies that shed light on the relative effectiveness of these measures. A historical review of communities in the US during the 1980s influenza pandemic identifies only 2 that escaped serious mortality and morbidity. Both communities had completely cut themselves off for months from the outside world. One was a remote town in the Colorado mountains, and the other was a naval training station on the island in San Francisco Bay. Obviously, this is not a strategy of general utility. Well, you're saying that now. Other studies have suggested that, except in the most extreme applications, disease mitigation measures have not had a significant impact on altering the course of an influenza pandemic. A number of mitigation measures that are now being considered could have a serious impact on the ability of the health system to deliver adequate care, and could have potentially adverse consequences for the provision of essential services. Many could result in significant disruption of the social functioning of communities and result in possible serious economic problems. Such negative consequences might be worth chancing if there was compelling evidence or reason to believe they would seriously diminish the consequence of spreading a pandemic. However, few analysts have been produced that weigh the hope for efficiency of such measures against the potential impact of large-scale or long-term implementation of these measures. I need a shot of coffee with this one, guys. Epidemiological expectations. Historically, it has been all but impossible to prevent influenza from being imported into a country or political jurisdiction, and there has been little evidence that any particular disease medication measure has significantly slowed the spread of the flu. The clinical and epidemiological characteristics of influenza explain why. The influenza virus is known to spread rapidly from one person to the next, with the second generation of patients occurring within 2 to 4 days following exposure. People infected with influenza may shed the virus for 1 to 2 days before becoming symptomatic. And this is why they're so much more worried about this, the current virus that's going around, because before you're becoming symptomatic, it's apparently a lot longer. Some flu-infected individuals may be asymptomatic, and so would not be recognized as being infected. In seasonal flu outbreaks, this group has represented a significant proportion of infected people. Asymptomatic individuals infected with flu have been shown to shed viruses, although the extent to which these individuals transmit infection to others is not known. I mean, that's surprising. You think this would be well, maybe, I guess it couldn't. Where'd be the funding to research it? Where would be the funding to research it? You'd expect there'd be funding from the WHO paying for these type of researchers to have scientific justification for, or to challenge anything that's put forward. But then just having a look at at what's going on in Davos, I think heterodox opinions perhaps aren't tolerated. Many patients who are symptomatic are not readily diagnosed because their symptoms differ little from individuals with other respiratory illnesses or allergies. Okay, people probably don't even know. Don't even know. I mean, how many times have you just said, I've never gotten sick, I've never gotten the flu, you can't remember? I mean, this year, and you can see it in my videos, I copped the flu, I copped it bad. It's probably the worst I've had in some time. But for years then, I don't remember ever getting it. Could just be I was asymptomatic. And we all get it every year. So, pandemic planning premise. A new pandemic strain can be expected to spread rapidly and widely, but it is not likely to be constantly present in any given area. In both 1918 and 57, there were some outbreaks in the US of disease in the late spring, but the outbreaks were geographically limited. This has been referred to as the first wave of the pandemic. There were very few cases in the summer, but in the autumn, a major pandemic wave of disease spread across the country during a 3 to 4 month period, the so-called second wave. This was followed by a comparatively quiescent period, and then a third wave occurred the following spring. Subsequently, the new strain in each of these pandemics displaced the then currently circulating strains and continued to recur every 2 to 3 years as seasonal flus, although it caused fewer serious illnesses. For planning purposes, the U.S. Department of Health and Human Services and the White House Homeland Security Council make the assumption that the expected attack rate in the next influenza pandemic would be comparable to the other 20th century pandemics. That is, about 25 to 30% of the population would become ill. It is also assumed that the virus's ability to spread rapidly and widely would be comparable to past pandemics, and that the duration of the outbreak in any given community should be about 8 weeks. While government planners estimate that as much as 30% of the US population would fall sick from the next pandemic, any given community would see those illnesses spaced out over a period of at least 8 weeks, not all occurring at one time. Since the average duration of the illness would be expected to be about 10 days, only a subset of flu victims in any community would be ill at once. Given this, even in the peak weeks of a pandemic, it would seem reasonable to expect no more than 10% of the community's population will be ill at any time. Now, I mean, this is an interesting point. We're discussing the flu here, so it's going to be different to what we're seeing with the COVID-19. But you have to understand the media, we always are hearing like total numbers, so many cases. When is it ever reported how many people are recovering? It might be some good news occasionally. So many people have recovered today. Fantastic. So many people have dropped off today. Last patient recovered. We need to hear that too. The HHS and HCS documents assume that in the worst case, the case fatality ratio would be equal to the 1918 pandemic, about 2.5%. Such data are available from the past 300 years, show the 1918 influenza pandemic was by far the most lethal. To date, the current H5N1 influenza case fatality ratio has been 50% or more. H5N1 infection has been clinically more severe, and many patients have exhibited symptoms that differ from those caused by other influenza strains. So far, the virus has exhibited little ability to spread from human to human. It has been widely assumed that if the current avian strain of virus did transform into one that is more readily transmittable, the virus would assume characteristics and case fatality rates more closely resembling previous pandemic strains. Because one would argue that it's obviously getting to people that are more susceptible. Comorbidities. Everyone. A range of possible measures for containing the spread of influenza during a pandemic are set forth in HHS's Pandemic Influenza Plan and HCS's National Strategy for Pandemic Influenza Implementation Plan. Both documents outline possible actions that might be taken during a pandemic to minimize transmission and control the spread of infection. Disease mitigation measures are not articulated, nor are operational details provided regarding how these measures should be implemented. It has been recognized that most actions taken to counter pandemic influenza will have to be undertaken by local governments, given that the epidemic response capacity of the federal government is limited. This is reflected in HHS Secretary Michael Livett's statement at the February 2006 State and Local Pandemic Preparedness Meeting. Any community that fails to prepare for an influenza pandemic, with the idea that somehow in the end the federal government will be able to rescue them, will be tragically wrong. Now, this ties into some other arguments I've been making, that decisions and leadership need to come from the ground up, need to come from the local level. But a recent review of the current pandemic influenza plans for 49 states reveal that few explicitly discuss implementing community mitigation strategies. The authors of the review attribute this lack of planning for influenza in part to weak central federal direction and lack of key epidemiological data. One of the best developed plans is that of New York City Department of Health and Mental Hygiene. Ooh, that didn't work out too well, did it? Whose staff considered the use of disease mitigation measures but decided to incorporate a few of the measures now described in federal plans. A fundamental premise of disease mitigation that has been advanced by some in the policymaking community is that a less intense but more prolonged pandemic may be easier for society to bear, but this is speculative. Well, we're seeing this play out in Sweden, aren't we? No. What do you think, guys? Would you prefer a less intense, more prolonged, or a more intense, less prolonged? And this is speculative. Well, it's not anymore. We're seeing the outcomes of it now. We're living through history. This will be recorded, measured, and will inform future mitigation strategies, hopefully. Hopefully. So, clarification of terms. There is widespread confusion about the terms used to describe measures for controlling disease spread. The principal confusion is between use of the words quarantine and isolation. Isolation properly refers only to the confinement of symptomatic patients in the hospital or at home, so they will not infect others. I think that's what's going on here. Quarantine has traditionally been defined as a separation from circulation in the community of asymptomatic people who may have been exposed to infection and might or might not become ill. Home quarantine refers to voluntary confinement of known contact of influenza cases in their own homes. Large-scale quarantine typically refers to confinement of large group of possibly infected people, for example, all passengers on an aeroplane, or the residents of an apartment building or an entire city, for periods of days to weeks. This is what we're seeing. Large-scale quarantine, guys. Right here. 6 weeks, an entire state. In recent years, the term social distancing has come into use. Social distancing has been used to refer to a range of measures that might serve to reduce contact between people. This may include closing schools, prohibiting large gatherings, such as church services and sporting events. Others have used the term to refer to actions taken to increase the distance of individuals from each other at the worksite or other locations. For example, substituting phone calls for face-to-face meetings or avoiding handshaking. The term has come to describe fundamentally different approaches to disease mitigation. This document will refer only to specific interventions rather than the catch-all term of social distancing. Evaluation of disease mitigation measures. The epidemiological assessment Do available data or experience suggest the measures will work? It is difficult to evaluate the effectiveness of specific measures to control disease spread in epidemiological terms, because of the complex interrelationship between individuals and groups and the individual biological differences in response to influenza. Some historical studies have tried to evaluate the efficacy of specific influenza containment efforts, and although they are informative and relatively paucity of such studies, and the differences between past historical moments and the present limit the conclusions that can be drawn. Recently, a number of mathematical models have examined various combinations of disease mitigation measures for pandemic influenza. Such models consist of computer simulations of disease outbreaks that are developed from very limited data regarding the epidemiological and biological characteristics of influenza, and a series of assumptions about the likely compliance of the population, the feasibility of applying various interventions, and so on. The predictions provided by such models can vary widely depending on the assumptions that are made in their construction. We see that with all modeling, with all computer modeling. The assumptions can radically change the outcome. That's why I'm so skeptical about making definitive predictions or prophetic declarations based on computer modeling. The only people that believe those are those that have never worked with them. So what the computer models cannot incorporate is the effect that various mitigation strategies might have on the behavior of the population and consequently course of the epidemic. There is simply too little experience to predict how a 21st century population would respond. For example, to the closure of all schools for periods of many weeks to months, or the cancellation of all gatherings of more than 1,000 people. Well, you can't even visit your neighbour now in certain parts of Australia. Would these closures serve to decrease contacts between people and so retard the spread of the epidemic? Or would those affected spend more time in malls or in fast food restaurants and in other social settings that might result in more contacts and more rapidly spread the influenza? No model, no matter how accurate its epidemiological assumptions, can illuminate or predict the secondary and tertiary effects of particular disease mitigation measures. Nor, for example, can it assess the potential effects of high absentee rates resulting from home or regional quarantine on the functioning integrity of essential services, such as hospital care or provision of food and electrical services to the community. If particular measures are applied for many weeks or months, the long-term or cumulative second and third order effects could be devastating socially and economically. In brief, models can play a contributory role in thinking and through possible mitigation measures, but they cannot be more than an ancillary aid in deciding policy. So, logical assessment. Is the disease mitigation measure feasible? And I'm going to have another shot of coffee. Many community-wide disease mitigation measures would be intrinsically difficult to implement. Consideration must be given to the resource required for implementation, to the mechanisms needed to persuade the public to comply, or compel the public if measures are mandatory. Well, welcome to Australia, guys. Welcome to Victoria. And to the length of time that will be needed to be applied. Potential disease medication measures presumably would have to be maintained for the duration of the epidemic in a community, a predicted period of 8 or more weeks, or perhaps in the country as a whole, as long as 8 months. 8 months. And I know this is influenza, but what are we starting to see here? 6 weeks, just 2 weeks. It's growing and growing, isn't it? Recent experience in endeavoring to quarantine a large number of people during the 2003 SARS outbreak illustrated why feasibility must be a central consideration. Canadian health officials implemented a voluntary home quarantine in Toronto, where an estimated 30,000 people who came in contact with SARS cases, fewer than 500 actual cases in all, were asked to stay home until it became clear they were not infected. Although the efficacy of the home quarantine in Toronto is not clear, the public health resources needed to implement this policy were prodigious. as it was necessary not only to persuade each family of the rationality of the measures and inform them how to comply, but also to arrange to provide food and other support services. As a result of this and other experiences, medical authorities have expressed doubt about the efficacy and feasibility of large-scale home quarantine. Social and economic and political assessments. What are the possible unintended adverse societal consequences? And I suspect we're starting to see that manifest. I was on the phone yesterday to a client in Victoria, and he's dealing with some people in his team that are suffering mental health issues. Here's the suggestion, guys. Just a reminder. There are going to be people who are alone, who are struggling through this, who are going to be stressed. Reach out to them. Reach out to them and talk to them. You know, people have asked me to do a video on mental health. Maybe I should. But, you know, the one thing I can encourage everyone to do is to reach out to people who are suffering through this. Disease mitigation measures, however well intended, have potential social, economic, and political consequences that need to be fully considered by political leaders as well as health officials. Closing schools is an example. Some have suggested closure might be recommended for as long as a pandemic persists in a single community, perhaps 8 weeks, or for as long as a pandemic persists in the country, 8 months. The rationale for the strategy is to diminish contact between students, so to retard the spread of the epidemic. However, if this strategy were to be successful, other sites where school children gather would also have to be closed. Daycare centres, cinemas, churches, fast food stores, malls, and athletic arenas. And they've done it. They've even closed parks. You couldn't go and play equipment for a period. Many parents would need to stay at home from work to care for children, which could result in high rates of absenteeism that could stress critical services, including healthcare. School closures also raise the question of whether certain segments of society would be forced to bear an unfair share of the disease control burden. A significant proportion of children in lower-income families rely on school feeding programs for basic nutrition. Political leaders need to understand the likely benefits and potential consequences of disease mitigation measures, including the possible loss of critical civic services and the possible loss of confidence in government to manage the crisis. So potential disease control measures, benefits and consequences. Large-scale community vaccination. Vaccinations are the best mechanism for preventing influenza infection and spread in the community, and for protecting healthcare workers caring for those who become ill. Once an influenza strain capable of sustained human-to-human transmission emerges, a vaccine specific to the pandemic strain will need to be made. It is expected that it will be at least 6 months after the emergence of the pandemic strain before the initial supplies of vaccine can be produced. Current vaccine manufacturing techniques and limitations on vaccine production constrain the total amount of vaccine that can be manufactured. Special efforts are being made to increase this capacity, but under current conditions, according to the National Strategy for Pandemic Influenza, it will be as much as 5 years, 2011, before domestic vaccine production is in place to create enough vaccine for the entire US population within 6 months of the start of a pandemic. It would be interesting to look into the production capacities now and to see at what level they are. So, isolation of sick people in hospitals. Beyond widespread vaccination, isolating symptomatic influenza patients either at home or in the hospital is probably the most important measure that could be taken to reduce the transmission and slow the spread of illness within a community. The sickest and presumably most contagious patients are most likely to seek hospital care. The critical importance of hospitals in providing health care during a pandemic cannot be overstated and has been addressed by a number of sources. Here's one thing. Weren't there cases of people who were ill sent to aged care homes? That's a concern. I've heard that happened in Ireland. Has that happened here in Australia? In an influenza epidemic, hospitals will face several key challenges. First, hospitals must protect their own staff from infection and avoid becoming amplifiers of disease. Historically, hospitals have often accelerated the spread of contagious disease because of the presence of highly contagious patients and the close proximity to the medical staff who care for them and to other patients who are ill and vulnerable to infection. Modern hospitals are not designed to accommodate large numbers of highly contagious patients, and special measures including cohorting of patients Adjustments to HVAC systems and use of PP gear will be needed to be made to protect healthcare workers and patients from infection. Second, hospitals must establish strategies for coping with what will presumably be the largest and relatively sustained surge in demand for medical care. At present, hospitals have little capacity to meet such demand. Hospital care will be needed not only for those who are ill with influenza itself, but also for patients with chronic conditions made critical by acute influenza infection. Accommodating the increased demand for hospital care will require coordination and collaboration between hospitals in a given region and among hospital leaders, public health authorities, and elected officials. Some jurisdictions have taken steps to establish the organizational framework, communication network, and operational principles needed to do this, but most have not. It is noteworthy that in spite of the predominant role that hospitals play in pandemic response, the federal allocation for pandemic flu preparedness have included little financial support either for regional medical care planning or for the hospitals themselves. And I suspect that may have changed, and that's why we're seeing people go, oh, why are the hospitals getting so much money every time they report such and such cases? I would imagine it's tied to this, to ensuring that they have the resources to deal with it. We'll have to see. In 1918 and 1919, even the best equipped hospitals had little to offer flu victims. Today, however, although modern medicine offers limited remedies for influenza, the availability of oxygen ventilators, antibiotics, and parenteral fluids could make a critical difference in surviving flu, especially among those with underlying chronic disease. It has been suggested that alternative care sites such as gymnasiums and armories could lessen the demand on hospitals. In 1918, such alternative care facilities were set up in many cities. However, patients housed in alternative sites received little more than food and water. Such sites realistically would represent alternatives to home care, not hospital care, given the practical problems of safely managing services such as respiratory support, intravenous medication, oxygen, and the like outside of a hospital setting. A major challenge for all authorities charged with managing a pandemic will be how to allot scarce, possibly life-saving medical resources and how to maintain hospitals' capacity to care for critically ill flu victims while continuing to provide other essential medical services. Home isolation of sick people. In light of the expected shortage of medical beds and personnel, home isolation of non-critically ill influenza patients would be necessary in a major pandemic. A policy that persuades sick individuals to voluntarily stay at home unless they are critically ill would allow hospitals to focus efforts on the most seriously threatened. There are a number of logistical considerations that could prevent people from being able to remain isolated in their home. Special measures will be needed to provide basic medical and food supplies, perhaps through the use of neighborhood volunteers, and supplemented by communication by phone and internet. It may not be easy to persuade those without paid sick leaves, some 59 million persons, to absent themselves from work unless employers address this problem directly. A recent review of state pandemic influenza plans found that only 1/3 of 49 states examined had explicitly planned to encourage voluntary home isolation. Use of antiviral medications. Antiviral drugs for influenza are available in limited quantities. Data on how antivirals might perform in the prevention or treatment of H5N1 strain are scant. Predominant authorities think the likelihood of quenching an emerging pandemic strain through the rapid region-wide use of antivirals is low because of technical and logistical difficulties, even if the pandemic strain proves to be sensitive to such drugs. Several countries have recommended that the top priority for antivirals is to treat the ill. If antivirals were to be used for prevention, it would imply the need for a much longer administration of the drug to cover the period of community epidemic, specifically using oseltamivir as the most available example, and quantity of antivirals used to prevent infection in a single healthcare worker during an 8 to 10 week epidemic period would serve to treat an estimated 5 to 7 patients, assuming prophylaxis with 75 milligrams twice daily for 8 to 10 weeks versus treatment with 150 milligrams twice daily for 5 days. Moreover, available data indicates that antiviral treatment is effective only if antivirals are given within 24 to 48 hours after the onset of initial symptoms. Some authorities doubt the feasibility of administering the drug soon enough to make a difference to the pandemic. That would make sense. I can see that as being a logistical nightmare, particularly if you wanted to spread it so far and wide. And then there'd be unintended consequences. And then wouldn't you lose the effectiveness of the antiviral if you deploy it so widespread? You'd increase the chance of an evolutionary response from the virus. Because of this concern, at least one Canadian teaching hospital is planning to use all its antiviral stocks for prophylaxis of healthcare workers. The European Union, on the other hand, decided not to stockpile any antiviral medicines, although some European countries have done so. The effectiveness and optimal use of antivirals remains uncertain because of several factors. The propensity of the influenza virus to mutate, thus increasing the possibility that resistance could develop. The quantities of antivirals required for prophylaxis and the logistical challenges involved in providing sufficiently rapid treatments. Contextual variables that cannot be predicted ahead of time, such as the quantity of medicines available and the development of resistance, will probably determine antiviral strategies. Hand washing and respiratory etiquette. One moment. It's a long one, guys, but it's important to have a look at. The influenza virus actually survives on the hand for less than 5 minutes. But regular hand washing is a common sense action that could be widely followed. It has been shown to reduce the transmission of respiratory illness in a military trainee setting, although there are no data to demonstrate that hand washing deters the spread of influenza within a community. General respiratory hygiene, such as covering one's mouth when coughing and using disposable paper tissues, is widely believed to be of some value in diminishing spread, even though there is no hard evidence that this is so. Large-scale quarantine measures. There are no historical observations or scientific studies that support the confinement by quarantine of groups of possibly infected people for extended periods in order to slow the spread of influenza. A World Health Organization writing group, after reviewing the literature and considering contemporary international experience, concluded that forced isolation and quarantine are ineffective and impractical. Despite this recommendation by experts, mandatory large-scale quarantine continues to be considered as an option by some authorities and government officials. The interest in quarantine reflects the view and conditions prevalent more than 50 years ago, when much less was known about the epidemiology of infectious disease, and when there was far less international and domestic travel in a less densely populated world. It is difficult to identify circumstances in the past half-century when large-scale quarantine has been effectively used in the control of any disease. The negative consequences of large-scale quarantine are so extreme: forced confinement of sick people with the well, complete restriction of movement of large populations, difficulty in getting critical supplies, medicines and food to people inside the quarantine zone, that this medication measure should be eliminated from serious consideration. Just a paper written by someone who just, some small experience in this matter, maybe eradicating smallpox from the planet. But why would our leaders even contemplate it? I mean, has there been any discussion of this? It's been very one-sided in the media and the news, hasn't it? Home quarantine. Voluntary home quarantine would be requested of individuals who are asymptomatic but who have had substantial contact with a person who has influenza, primarily household members. The aim of voluntary home quarantine is to keep possible contagious but still asymptomatic people out of circulation. This sounds logical, but this measure raises significant practical and ethical issues. If implemented on a community-wide scale, logistical requirements relating to ensuring that quarantined households across a community had appropriate care and support would be necessary. How compliant the public might be is uncertain. Parents would presumably be willing to stay home and care for sick kids, but it is not known, for example, whether college students would agree to be interned with infected dorm mates. Even if home quarantine were generally acceptable to the community, individuals may not have the economic resources to stay at home. Few employers currently have provisions for paid absence unless the worker themselves are ill. For those who are hourly workers or who are self-employed, the potential loss of wages as a result of having to stay at home simply because an individual had had contact with sick people may not be acceptable or feasible. Well, home quarantine also raises ethical questions. Implementation of home quarantine could result in healthy, uninfected people being placed at risk of infection from sick household members. Practices to reduce the chance of transmission, hand washing, maintaining a distance of 3 feet from infected people, etc., could be recommended, but a policy imposing home quarantine would preclude, for example, sending healthy children to stay with relatives when a family member became ill. Such a policy would also be practically hard on and dangerous to people living in closed quarters, where the risk of infection would be heightened. Travel restrictions. Travel restrictions. Travel restrictions such as closing airports and screening travelers at borders have historically been ineffective. The World Health Organization writing group concluded that screening and quarantining entire travelers at international borders did not substantially delay virus introduction in past pandemics and will likely be less effective in the modern era. Well, I mean, we've seen that, haven't we? We've seen that even when they put them all in hotels. It didn't work. All the security guards were getting jiggy with it. Similar conclusions were reached by public health authorities involved in the international efforts to control SARS. Canadian health officials report that available screening measures for SARS were limited in their effectiveness as detecting SARS among inbound or outbound passengers from SARS-affected areas. A review by the World Health Organization Working Group on SARS also concluded that entry screening of travelers through health declarations or thermal scanning at international borders had little documented effect on detecting SARS cases. The authorities have concluded in a previous analysis that screening individuals on domestic interstate flights for symptoms of flu, as has been proposed in revisions to the federal quarantine rule, would not be effective and would have serious adverse consequences. It is reasonable to assume that the economic cost of shutting down air or train travel will be very high. Well, we've seen it, haven't we? And the societal costs involved in interrupting all air or train travel would be extreme. Shutting down public transportation for an extended period is not an option in many cities. In New York, an average of 4.7 million people ride the subway each weekday. In Los Angeles, the metro averages 1.3 million riders. So prohibiting social gatherings. During seasonal influenza epidemic, public events with an expected large attendance have sometimes been cancelled or postponed, the rationale being to decrease the number of contacts, unless you're in a protest, of course, with those who might be contagious. There are, however, no certain indications that these actions have had any definitive effect on the severity or duration of an epidemic. Where consideration to be given to doing this on a more extensive scale and for an extended period, questions immediately arise as to how much such events would be affected. There are many social gatherings that involve close contact among people, and this prohibition may include church services, athletic events, perhaps meetings of more than 100 people. It might mean closing theaters, restaurants, malls, large stores and bars. Implementing such measures would have seriously disruptive consequences for a community. If extended through the 8-week period of an epidemic in a municipality area, let alone if it were to be extended through the nation's experience with a pandemic of perhaps 8 months. In the event of a pandemic, attendance at public events or social gatherings could well decrease because people were fearful of becoming infected, and some events might be cancelled because of local concerns. But a policy calling for community-wide cancellation of public events seems inadvisable. Need another shot of coffee, guys. School closures. It's interesting that all of these things have been implemented here in Australia. They haven't, travel restrictions. We're down to 5 kilometres in Victoria. School closures. In previous influenza epidemics, the impact of school closing on illness rates has been mixed. A study from Israel reported a decrease in respiratory infections after a 2-week teacher strike, but the decrease was only evident for a single day. On the other hand, when schools closed for a winter holiday during the 1918 pandemic in Chicago, more influenza cases developed among pupils than when school was in session. So, I mean, they'll probably be playing anyway. Schools are often closed for 1 to 2 weeks early in the development of seasonal community outbreaks of influenza, primarily because of high absentee rates, especially in elementary school, and because of illness among teachers. This would seem reasonable on practical grounds. However, to close schools for longer periods is not only impractical but carries the possibility of a serious adverse outcome. For example, for working parents, schools serve as a form of daycare. Oh, they said it. I can't believe they said it. They said it. And in some areas, a source of nutritional meals for children from lower income families. In 2005, some 29.5 million children were fed through the National School Lunches Program. 9.3 million children received meals as part of a school breakfast program. A portion of America's workforce will be unable to go to work as long as children were out of school. Heightened absentee rates could cripple essential services industries. Teachers might not be paid, and a great many hourly workers, mall and fast food employees, school janitorial, security and kitchen staff, bus drivers would face particularly financial hardships. So this is why the unions are calling for the funding of the police in the US before they'll open the schools. But I mean, that's a whole other mess that isn't even part of this topic. So maintaining personal distance. It has been recommended that individuals maintain a distance of 3 feet or more during a pandemic so as to diminish the number of contacts with people who may be infected. The efficacy of this measure is unknown. It is typically assumed that transmission of droplet-spread diseases such as influenza is limited to close contacts, that is within 3 to 6 feet of an infected person. Keeping a space of 3 feet between individuals may be possible in some work environments, but it is difficult to imagine how bus, rail, or air travelers could stay 3 feet apart from each other throughout an epidemic. And such a recommendation would greatly complicate normal daily tasks like grocery shopping, banking, and the like. Use of masks and personal protective equipment. Masks and other PPE are essential for controlling transmission of influenza in hospitals. Isn't it funny how we receive such mixed messages from the media, guys? For people who work in hospitals, current CDC guidelines for influenza infection control recommend droplet precautions, including the use of surgical masks. But HHS planning guidelines also rightly acknowledge that the uncertainties regarding the potential of virus transmission at the start of a new pandemic would recommend that airborne precautions be used in hospitals, that is N95 masks already in short supply, or powered air purifying respirators. Patients would be advised to wear surgical masks to diminish the number of infectious respiratory particles being dispersed in the air, thereby diminishing the likelihood of further spread. In Asia, during the SARS period, many people in the affected communities wore surgical masks when in public, but studies have shown that the ordinary surgical mask does little to prevent inhalation of small droplets bearing influenza virus. The pores on the mask become blocked by moisture from breathing, and the airstream simply diverts around the mask. There are few data available to support the efficacy of N95 or surgical masks outside of healthcare settings. N95 masks need to be fit tested to be efficacious and uncomfortable to wear for more than an hour or two. More important, the supply of such masks are too limited to even ensure hospitals will have necessary reserves. So that's why we're getting the mixed messages here, because of this. The problem is, when you fit them, you've got to do it properly. Community response to a pandemic, a summary of possible actions. There is no question but another influenza pandemic will occur, and that every community needs to be prepared for that eventuality. Influenza is unlike any other disease epidemic in the rapidity with which it spreads. As it emerges, the number of illnesses that it can cause over a period of a few months. It is unpredictable as to when a pandemic may begin. It could be next autumn, it may not be for a number of years. The world has weathered 3 pandemics during the past century and will certainly surmount the next one. How much damage the pandemic will cause depends to a large extent on the state of readiness of each community and each metropolitan region and the efficacy and reasonableness of its response. The following is a synopsis of the author's judgment regarding possible disease mitigation measures. Vaccination. Vaccination is by far the most important preventative measure, but pandemic strain vaccine will not be available for at least the next season. Meanwhile, community-wide use of the seasonal influenza vaccine is desirable, as it is likely that outbreaks of seasonal flu will occur even if there is a pandemic influenza. I mean, that's one thing my mother asked me. There's little no advertising encouraging people to get the seasonal influenza vaccine. Because wouldn't you want that to minimize the risk of people getting the flu and then having to be hospitalized? Or did I just not see it? I mean, I don't bother with it because I consider myself young and I'm not really exposed to people in my job. I can understand why healthcare workers would take advantage of it and why it's required. I can appreciate that. Provision for isolation and medical care of influenza patients. A regional healthcare operations committee is a priority. Needs to assure collaboration and cooperation across the community, hospitals, medical care providers, Red Cross, law enforcement, media and others, both for advancing planning and during the epidemic to ensure that a large number of flu-infected patients can be cared for in hospital, at home or in special facilities. Special arrangements are needed for expanding surge capacity in hospitals. Has that happened here in Australia? For support to permit care of patients and the provision of additional volunteer healthcare staff. A communication strategy and plans. Open and frequent communication with the public are essential. This involves regular press conferences, hotlines and provision of information through civic leaders, churches, schools and businesses. An important message is to request that all who are ill remain isolated at home or in hospital, to encourage others to continue to come to work so that essential services can be sustained. Closure of schools. It has been practical in many communities to close schools for 10 to 15 days at the beginning of an epidemic of seasonal flu, primarily because of the number of both teachers and pupils who are absent. This is a reasonable initiative, often expected in many communities, that also serves to demonstrate action on the part of officials. Closing schools for longer periods in hopes of mitigating the epidemic by decreasing contact among students is not warranted unless all other likely points of assembly are closed. Malls, fast food restaurants, churches, recreation centres, etc. Such widespread closures sustained through the pandemic would almost certainly have serious adverse social and economic effects, and we're starting to see the consequences of that. Hand washing and respiratory hygiene. Everyone should be encouraged to wash their hands after coming in contact with people who are ill, or to cover their mouths when coughing or sneezing. Cancelling or postponing meetings or events involving large numbers of people. Intuitively, this would appear to be a helpful adjunct to reduce contact among people and so mitigate the effects of the epidemic. However, individuals normally have a great many contacts throughout the community on a daily basis, shopping in stores, attending churches, travelling on public transport, and so on. Recognizing that the spread of influenza is primarily by person-to-person contact, any one individual, even in a large gathering, would only have a limited number of such close encounters with infected people. Thus, cancelling or postponing large meetings would not be likely to have any significant effect on the development of the epidemic. While local concerns may result in the closure of particular events for logistical reasons or logical reasons, a policy directing community-wide closures of public events seems inadvisable. Quarantine. As experience shows, there is no basis for recommending quarantine of either groups or individuals. The problems in implementing such measures are formidable, and secondary effects of absenteeism and community disruption, as well as possible adverse consequences such as a loss of public trust in government and stigmatization of quarantined people and groups are likely to be considered. Screening passengers at borders or closing air or rail travels. Experience has shown that these actions are not effective and could have serious adverse consequences, thus are not recommended, which is surprising. So, an overriding principle. Experience has shown that communities faced with epidemics or other adverse events respond best and with the least anxiety when the normal social functioning of the community is least disrupted. Strong political and public health leadership to provide reassurance and to ensure that needed medical care services are provided are critical elements. If either is seen to be less than optimal, a manageable epidemic could move towards a catastrophe. And here we have all of the references that were used in this paper. Now, I will link to this. You can find it, the reference link, on my blog and in the description below. What do you all think, everyone? It's interesting to see all of the concerns that they highlighted due to some of these mitigation strategies that have been implemented. So you can start to see why they've pushed out JobKeeper, why they've increased JobSeeker to try and mitigate some of the warnings that they've put forward. Do you agree with the interventions of the state? Would you think that we should listen to some of these other suggestions? And has anyone seen any discussion like this in the media, in the news, or in public? Let me know your thoughts and opinions in the comments below. Thank you all for watching, and thank you for the viewer who encouraged me to go through this. It's, oh bloody hell, it's been a 1 hour episode. But it's important to discuss these things. It is important to discuss these things and to look at other epidemiological responses and some information. As always, thank you for watching. Please let me know your thoughts and opinions in the comments below. Please like, share, and subscribe to the channel. If you're a fan and want to support the content I create here, there are a few ways you can. You can join the channel on YouTube or Patreon. You can support us using our affiliate links at Amazon, eBay, Independent Reserve, or Kucoin. You can buy merch from HeiseSays, use Gold Pass from the Perth Mint, or support us via PayPal. Take care, everyone. I'll see you all in the next episode.